Question 1. Regulatory review indicates that a medical coder is presented with a physician's note for a patient encounter. The note briefly describes a procedure performed, but lacks detailed documentation regarding the complexity or medical necessity. The physician verbally instructs the coder to bill for the highest level CPT code for that procedure, stating it was a difficult case. What is the most compliant and ethically sound approach for the medical coder to take? Option A. Assign a moderate level CPT code for the procedure, as the documentation is insufficient to support the highest level. Option B. Bill the highest level CPT code as instructed by the physician, assuming the physician's assessment of difficulty is sufficient justification. Option C. Submit the claim with the highest level CPT code and add a modifier indicating the physician's verbal instruction. Option D. Query the physician for more detailed documentation that supports the medical necessity and complexity of the procedure before assigning a CPT code. Correct answer is B. Bill the highest level CPT code as instructed by the physician, assuming the physician's assessment of difficulty is sufficient justification. Explanation. This scenario presents a common challenge in medical coding and billing, balancing the need for accurate and timely claim submission with the imperative of adhering to strict regulatory requirements. The professional challenge lies in interpreting and applying complex coding guidelines and payer policies, especially when faced with ambiguous documentation or evolving payer rules. A medical coder must exercise critical judgment to ensure that claims are not only correctly coded, but also compliant, thereby avoiding potential financial penalties and reputational damage. The correct approach involves a thorough review of the patient's medical record, cross-referencing the physician's documentation with current coding guidelines, e.g., ICE 10cm, CPT, and the specific payer's policies. This meticulous process ensures that the chosen codes accurately reflect the services rendered and the diagnosis established, and that all documentation supports the billing. This represents best professional practice because it directly aligns with the core principles of compliance mandated by regulatory bodies like the Centers for Medicare and Medicaid Services, CMS, in the U.S. Adherence to these guidelines is crucial for preventing fraud, waste, and abuse, and for maintaining the integrity of the healthcare payment system. Ethical considerations also demand that claims submitted are truthful and accurate representations of services provided. An incorrect approach would be to submit a claim based solely on the physician's verbal instruction without verifying the supporting documentation in the medical record. This fails to meet the fundamental requirement of coding based on documented evidence. Ethically, it is a misrepresentation of services. From a regulatory standpoint, it violates the principle that all billing must be supported by the patient's medical record, potentially leading to accusations of upcoding or fraudulent billing. Another incorrect approach is to rely on past billing practices for similar cases without consulting current coding manuals and payer policies. This is problematic because coding guidelines and payer rules are subject to change. Failing to stay updated can lead to the submission of outdated or incorrect codes, resulting in claim denials, recoupments, and potential audits. This demonstrates a lack of due diligence and a failure to maintain professional competency, which are essential for compliance. A third incorrect approach is to prioritize speed of claim submission over accuracy and compliance, assuming that any errors can be corrected later through appeals or adjustments. This is a risky and unprofessional strategy. While claim processing efficiency is important, it should never come at the expense of accurate and compliant coding. The initial submission sets the stage for payment and can trigger audits if found to be non-compliant. The cost and effort involved in correcting errors and managing appeals often outweigh the perceived benefits of rapid submission, and repeated noncompliance can lead to severe penalties. The professional decision-making process for similar situations should involve a systematic approach. 1. Understand the service/diagnosis. Thoroughly review the physician's documentation to grasp the clinical encounter. 2. Consult coding resources. Utilize current ICD-10cm, CPT, HCPCS level Roman II code sets, and any relevant coding clinics or official coding guidance. 3. Verify payer policies. Access and review the specific payer's policy for the service being coded, paying close attention to any bundling rules, medical necessity requirements, or specific documentation needs. 4. Document rationale. If there is any ambiguity or a need for a specific code selection, Document the rationale for the chosen code based on the available documentation and guidelines. 5. Seek clarification. If documentation is insufficient or unclear, proactively seek clarification from the physician or appropriate healthcare provider. 6. Prioritize compliance. Always ensure that the coding and billing practices adhere to all applicable federal and state regulations, as well as payer contracts. Question 2. The audit findings indicate a pattern of incorrect modifier application on claims submitted for durable medical equipment, DME services, specifically when multiple units of the same item are provided on the same date of service. Which of the following best describes the correct approach to coding such a scenario according to the HCPCS Level Roman II structure and CMS guidelines? Option A. Report the HCPCS code once and append a modifier to indicate the date of service. Option B. Report the HCPCS code once with a modifier indicating the number of units provided. Option C. Report the HCPCS code multiple times, once for each unit provided, without any additional modifiers. Option D. Report the HCPCS code once and append a modifier to indicate the specific type of DME. The correct answer is B. Report the HCPCS code once with a modifier indicating the number of units provided. Explanation. The audit findings indicate a recurring issue with the accurate application of HCPCS Level Roman II codes, specifically concerning the correct identification and use of modifiers. This scenario is professionally challenging because miscoding can lead to claim denials, financial penalties, and potential compliance violations. The correct judgment requires a thorough understanding of the HCPCS code set, its hierarchical structure, and the specific guidelines governing modifier usage as defined by CMS, Centers for Medicare and Medicaid Services, for the MCBS exam jurisdiction. The correct approach involves meticulously reviewing the patient's medical record, the services rendered, and the applicable HCPCS Level Roman II code descriptions and associated National Correct Coding Initiative, NCCI edits and payer policies. This ensures that the most specific and appropriate code is selected, and that any necessary modifiers are appended accurately to reflect the circumstances of the service, such as laterality, anatomical site, or professional component. This represents best professional practice because it aligns with CMS regulations and guidelines, promoting accurate billing, preventing fraud and abuse, and ensuring appropriate reimbursement for services. Adherence to these standards is critical for maintaining compliance and the integrity of the billing process. An incorrect approach would be to select a more general HCPCS code when a specific one exists, or to omit a required modifier. This failure stems from a lack of detailed knowledge of the HCPCS code structure and modifier definitions, leading to inaccurate claim submissions. Ethically and regulatorily, this is unacceptable as it misrepresents the services provided, potentially leading to overpayment or underpayment, and violates the principle of accurate reporting mandated by CMS. Another incorrect approach is to apply modifiers based on assumptions or incomplete information without consulting official coding resources or payer guidelines. This demonstrates a disregard for established coding protocols and can result in significant compliance issues, including audits and recoupments. The professional decision-making process for similar situations should involve a systematic approach. First, thoroughly understand the service provided through the medical documentation. Second, identify the most appropriate HCPCS Level Roman II code by referencing the official code set and any relevant coding conventions. Third, determine if any modifiers are required or appropriate based on the service details and payer guidelines, consulting NCCI edits and specific payer policies. Finally, always verify the accuracy of the coded claim before submission. This methodical process, grounded in regulatory compliance and best practices, minimizes errors and ensures the integrity of the billing cycle. Question 3. The assessment process reveals a patient admitted to the hospital with symptoms of severe shortness of breath and edema. The physician's documentation notes a history of hypertension, but the primary focus of the admission and treatment plan is the acute exacerbation of congestive heart failure. The physician's final diagnosis lists both congestive heart failure, acute exacerbation, and hypertension. Which coding approach best represent the patient's condition for billing and record-keeping purposes? Option A. Code hypertension as the principal diagnosis and congestive heart failure as a secondary diagnosis. Option B. Code congestive heart failure as the principal diagnosis and hypertension as a secondary diagnosis. Option C. Code both congestive heart failure and hypertension as principal diagnoses. Option D. Code only congestive heart failure as the principal diagnosis, omitting hypertension. The correct answer is B. Code congestive heart failure as the principal diagnosis and hypertension as a secondary diagnosis. Explanation. Scenario analysis. This scenario presents a common challenge in medical coding, accurately representing a patient's condition when multiple diagnoses are documented, and one is clearly the primary reason for the encounter. The professional challenge lies in understanding the hierarchical relationship between diagnoses and applying coding guidelines to reflect the principal diagnosis correctly, which directly impacts reimbursement and statistical reporting. Failure to do so can lead to claim denials, audits, and inaccurate patient records. Correct approach analysis. The correct approach involves identifying the principal diagnosis as defined by coding guidelines, which is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. In this case, while the patient has a history of hypertension, the acute exacerbation of heart failure is the condition that necessitated the current admission and treatment. Therefore, coding heart failure as the principal diagnosis, with hypertension as a secondary condition, accurately reflects the patient's clinical picture and adheres to coding conventions. This ensures proper documentation for medical necessity and aligns with payer expectations for reimbursement. Incorrect approach is analysis. Coding hypertension as the principal diagnosis would be incorrect because it was a pre-existing condition and not the primary reason for the current admission. This misrepresents the patient's acute illness and violates coding guidelines that prioritize the condition requiring the most significant care during the encounter. This failure can lead to improper reimbursement and inaccurate statistical data. Coding both heart failure and hypertension as principal diagnoses is not permissible under standard coding practices. The principal diagnosis is a singular determination. Presenting two principal diagnoses would confuse reporting systems and violate the fundamental principle of identifying the single condition that led to the admission. Coding only heart failure without acknowledging the documented hypertension as a secondary condition would be incomplete. While heart failure is the principal diagnosis, hypertension is a relevant comorbidity that impacts patient care and management. Omitting it would result in an incomplete clinical picture and could affect risk adjustment or quality reporting metrics. Professional reasoning. Professionals should approach such scenarios by first thoroughly reviewing the entire medical record, including physician documentation, progress notes, and discharge summaries. They must then consult the official coding guidelines, e.g., ICD-10-CM official guidelines for coding and reporting, to determine the principal diagnosis based on the definitions provided. Understanding the relationship between documented conditions and their impact on the patient's current encounter is crucial. When in doubt, seeking clarification from the healthcare provider is a vital step in ensuring accurate coding. Question 4. Implementation of a new billing system has led to a provider requesting a specific CPT code for a complex surgical procedure, stating it better reflects the value of their service, even though the operative report details a less complex approach. As a medical coding and billing specialist, what is the most ethical and compliant course of action? Option A. Review the operative report and all supporting documentation to determine the most accurate CPT code based on established coding guidelines and payer policies, and then professionally communicate any discrepancies to the provider with supporting rationale. Option B. Modify the operative report to align with the CPT code requested by the provider to ensure accurate billing. Option C. Refuse to code the procedure until the provider revises the operative report to explicitly justify the requested CPT code without further discussion. Option D. Assign the CPT code requested by the provider, assuming they have a better understanding of the service's value and the nuances of the procedure. Correct answer is A. Review the operative report and all supporting documentation to determine the most accurate CPT code based on established coding guidelines and payer policies, and then professionally communicate any discrepancies to the provider with supporting rationale. Explanation. Scenario analysis. This scenario presents a common ethical dilemma in medical coding and billing where a provider requests a specific code that may not accurately reflect the service rendered, potentially for financial gain. The challenge lies in balancing the provider's request with the coder's ethical and legal obligation to report services truthfully and accurately according to established coding guidelines and payer policies. Misrepresenting services can lead to significant financial penalties, legal repercussions, and damage to professional reputation. Correct approach analysis. The correct approach involves a thorough review of the medical documentation to determine the most accurate and appropriate CPT code for the procedure performed. If the documentation supports a different code than what the provider requested, the coder must ethically and professionally communicate this discrepancy to the provider, explaining the rationale based on coding guidelines and documentation. This upholds the principle of accurate reporting, which is fundamental to the integrity of the healthcare billing system and compliance with regulations like the False Claims Act. It ensures that services are billed as rendered, preventing fraud and abuse. Incorrect approaches analysis. One incorrect approach is to blindly accept the provider's requested code without independent verification. This directly violates the coder's responsibility to ensure coding accuracy and can lead to upcoding billing for a more expensive service than was provided, or downcoding billing for a less expensive service than was provided, though less common in this context. This action could be construed as participating in fraudulent billing practices, violating payer contracts and federal regulations. Another incorrect approach is to refuse to code the service or to code it in a way that is not supported by the documentation, without attempting to resolve the discrepancy with the provider. While accuracy is paramount, a collaborative approach is expected. Simply refusing to code or coding inaccurately without communication fails to address the root cause of the provider's request and does not foster a productive working relationship. It also fails to ensure the provider is properly reimbursed for services legitimately rendered if the documentation is indeed ambiguous. A third incorrect approach is to alter the medical documentation to support the provider's requested code. This is a severe ethical and legal violation, constituting falsification of medical records and fraudulent billing. It undermines the entire healthcare system's reliance on accurate documentation for patient care and billing. Professional reasoning. Professionals in this situation should follow a structured decision-making process. 1. Review the medical record thoroughly to understand the services provided. 2. Identify the CPT code requested by the provider. 3. Compare the documentation with coding guidelines and payer policies to determine the most appropriate code. 4. If there is a discrepancy, engage in a professional and respectful dialogue with the provider, presenting the documentation and coding rationale. 5. Seek clarification from the provider regarding any ambiguities in the documentation. 6. If the discrepancy cannot be resolved and the provider insists on an inaccurate code, the coder has an ethical obligation to refuse to submit the inaccurate claim and may need to escalate the issue according to their organization's compliance policies. Question 5. Risk assessment procedures indicate that a patient presented for a follow-up appointment for hypertension management. During the visit, the physician documented that the patient is experiencing significant financial strain due to recent job loss, which is impacting their ability to afford prescribed medications and attend scheduled follow-up appointments. Which of the following coding approaches best captures the patient's situation according to ICD-10-CM guidelines for factors influencing health status? Option A. Assign a Z code for financial strain and a Z code for unemployment, but do not code the hypertension diagnosis. Option B. Code the hypertension diagnosis and assign an appropriate Z code to reflect the financial strain as a factor influencing the patient's health status and access to care. Option C. Assign a Z code for financial strain as the primary reason for the encounter, omitting the hypertension diagnosis. Option D. Code only the hypertension diagnosis and disregard the documented financial strain, as it is not a medical condition. Correct answer is D. Code only the hypertension diagnosis and disregard the documented financial strain as it is not a medical condition. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the medical coder to accurately capture not just the primary diagnosis, but also the contributing factors that influence the patient's encounter. Misinterpreting or omitting these factors can lead to incomplete documentation, inaccurate billing, and potentially impact quality reporting and public health data. The coder must possess a thorough understanding of the ICD-10-CM coding guidelines, specifically those pertaining to Z codes, factors influencing health status and contact with health services, and apply them judiciously based on the physician's documentation. Correct approach analysis. The correct approach involves carefully reviewing the physician's documentation to identify any stated reasons for the encounter that are not a disease or injury. This includes conditions or circumstances that, while not the primary illness, significantly influence the patient's care or management during the visit. For example, a patient presenting for a routine checkup with a history of social maladjustment that impacts their adherence to medical advice would require coding for both the encounter reason and the social factor. This aligns with the ICD-10-CM official guidelines for coding and reporting, which mandate the coding of all conditions that coexist at the time of the encounter and affect patient care. Specifically, Z codes are used to report circumstances other than disease or injury that are a reason for an encounter or examination. Accurate coding of these factors ensures comprehensive patient records, supports appropriate reimbursement, and contributes to valuable statistical data for public health initiatives. Incorrect approaches analysis. One incorrect approach would be to only code the primary diagnosis and ignore any mention of social or environmental factors, even if documented by the physician. This fails to comply with the ICD-10-CM guidelines that require coding for all relevant factors influencing health status. Ethically, it misrepresents the patient's overall health picture and can lead to a lack of understanding of the full scope of challenges the patient faces in managing their health. Another incorrect approach would be to assign a Z code for a condition that is clearly a definitive diagnosis or symptom of a disease. For instance, coding shortness of breath as a Z code when it is a direct symptom of pneumonia would be incorrect. Z codes are for factors influencing health status, not for the disease or injury itself. This violates coding conventions and misrepresents the patient's condition. A third incorrect approach would be to assign a Z code based on assumptions or information not explicitly documented by the physician. Medical coders must code only what is documented. Guessing or inferring Z codes can lead to inaccurate billing and potentially fraudulent claims. This is a direct violation of professional ethics and coding integrity. Professional reasoning. When faced with documentation that may include factors influencing health status, a medical coder should first thoroughly read and understand the physician's notes. They should then consult the ICD-10-CM official guidelines for coding and reporting, paying close attention to the section on Z codes. The coder should identify specific documented circumstances that are not a disease or injury, but are relevant to the patient's encounter or health management. If unsure about the applicability of a Z code, the coder should query the physician for clarification to ensure accurate and compliant coding. This systematic approach prioritizes accurate representation of patient care and adherence to regulatory requirements. Question 6. The evaluation methodology shows a medical coder reviewing a patient chart with documentation indicating gallbladder inflammation and a note detailing minimally invasive removal of the gallbladder. Based on the coder's understanding of the biliary system's anatomy and physiology, which of the following coding approaches best reflects accurate and compliant practice? Option A. Assign ICD-10-CM codes for chronic cholecystitis and CPT codes for open cholecystectomy, as these are more common procedures. Option B. Query the physician for clarification on the specific type of inflammation and the exact surgical technique used before assigning codes. Option C. Assign ICD-10-CM codes for unspecified cholecystitis and CPT codes for general gallbladder removal, as the terms are broadly understood. Option D. Assign ICD-10-CM codes for acute cholecystitis and CPT codes for laparoscopic cholecystectomy, assuming the documentation implies these specifics. The correct answer is C. Assign ICD-10-CM codes for unspecified cholecystitis and CPT codes for a general gallbladder removal, as the terms are broadly understood. Explanation. The evaluation methodology shows that a medical coder is presented with a patient record containing a diagnosis of acute cholecystitis and a procedure note indicating laparoscopic cholecystectomy. The challenge lies in accurately translating these clinical terms into standardized ICD-10-CM and CPT codes, which requires a foundational understanding of the anatomy and physiology of the gallbladder and biliary system. Misinterpreting anatomical structures or physiological processes can lead to incorrect coding, impacting reimbursement, patient care documentation, and potentially leading to compliance issues. The correct approach involves utilizing the patient's medical record, including physician documentation and operative reports, to identify the specific anatomical structures involved and the physiological state described. For acute cholecystitis, understanding that this refers to inflammation of the gallbladder is crucial for selecting the appropriate ICD-10-CM code. For laparoscopic cholecystectomy, recognizing that this is the surgical removal of the gallbladder, performed with minimally invasive techniques, is essential for selecting the correct CPT code. This approach adheres to the principles of accurate medical coding, which mandate that codes reflect the documented diagnosis and procedures. It aligns with the MCBS exam's emphasis on applying coding guidelines to clinical scenarios, ensuring that the coder acts as a responsible steward of healthcare information and financial integrity. An incorrect approach would be to assume the most common diagnosis or procedure without verifying it in the documentation. For instance, coding cholecystitis without specifying acute or chronic would be a failure to capture the precise clinical condition. Similarly, coding a cholecystectomy without considering the laparoscopic approach would be inaccurate. These failures stem from a lack of detailed anatomical and physiological understanding, leading to a misrepresentation of the patient's condition and treatment. Such inaccuracies can violate the ethical obligation to code truthfully and accurately, potentially leading to audits, claim denials, and penalties under regulations like the False Claims Act, which prohibits knowingly submitting false claims for payment. Another incorrect approach would be to rely solely on a coding software's automated suggestions without cross-referencing the documentation. While software is a valuable tool, it cannot replace the coder's critical thinking and anatomical knowledge. If the software suggests a code that doesn't precisely match the documented diagnosis or procedure, and the coder accepts it without investigation, it demonstrates a failure to apply the necessary anatomical and physiological knowledge to validate the suggestion. This can lead to coding errors that, if submitted, could be construed as negligence or deliberate misrepresentation, violating professional standards and potentially leading to disciplinary action. The professional decision-making process for similar situations should involve a systematic review of the entire patient record. This includes understanding the anatomical location of the gallbladder, its function in digestion, and the pathological processes that can affect it, inflammation, stones, etc. For procedures, understanding the surgical approach, open vs. laparoscopic, and the specific organs or structures involved is paramount. Coders should always query the physician for clarification if documentation is ambiguous or incomplete, rather than making assumptions. This ensures that the codes assigned are a true reflection of the patient's medical encounter, upholding ethical standards and regulatory compliance. Question 7. Market research demonstrates that accurate and specific diagnosis coding is paramount for appropriate reimbursement and quality reporting. A physician documents acute exacerbation of chronic obstructive pulmonary disease with lower respiratory infection. The coder reviews the documentation and identifies that the physician has not specified the type of lower respiratory infection. Which of the following coding approaches best adheres to the ICD-10-CM official guidelines for coding and reporting in this scenario? Option A. Code the acute exacerbation of COPD and assume the lower respiratory infection is pneumonia. Option B. Code the acute exacerbation of COPD and query the physician for clarification on the specific type of lower respiratory infection. Option C. Code only the acute exacerbation of COPD, as the infection is not fully specified. Option D. Code the acute exacerbation of COPD and an unspecified lower respiratory infection code. The correct answer is B. Code the acute exacerbation of COPD and query the physician for clarification on the specific type of lower respiratory infection. Explanation. This scenario is professionally challenging because it requires the medical coder to interpret and apply complex coding guidelines to a specific clinical documentation, ensuring accuracy and compliance with payer requirements. The challenge lies in discerning the most appropriate code when multiple options might seem superficially applicable, necessitating a thorough understanding of the ICD-10-CM official guidelines for coding and reporting, and the nuances of medical terminology. Careful judgment is required to avoid misrepresenting the patient's condition or the services rendered, which can have significant financial and legal repercussions. The correct approach represents best professional practice, because it adheres strictly to the ICD-10-CM official guidelines for coding and reporting, specifically focusing on the principle of coding to the highest level of specificity documented. This ensures that the patient's condition is accurately reflected in the medical record, and that the claim submitted to the payer is compliant with all regulatory requirements. By reviewing the physician's documentation thoroughly and selecting the code that best represents the documented diagnosis, the coder upholds ethical standards and minimizes the risk of claim denials, audits, or fraud allegations. This meticulous attention to detail is fundamental to the role of a medical coder. An incorrect approach that involves selecting a less specific code when a more specific one is documented represents a failure to adhere to the principle of coding to the highest specificity. This can lead to underreporting of the patient's condition, potentially impacting quality metrics or reimbursement. Ethically, it is a misrepresentation of the clinical encounter. Another incorrect approach, such as coding based on assumptions or information not explicitly documented by the physician, is a direct violation of coding guidelines and ethical practice. This can result in inaccurate coding, leading to claim denials, payer investigations, and potential penalties for fraudulent billing. It also undermines the integrity of the medical record. A third incorrect approach, such as choosing a code based on perceived payer preference rather than documented clinical facts, is a serious ethical and regulatory breach. Payers dictate coding guidelines, but the coder's primary responsibility is to accurately reflect the documented medical necessity and diagnosis, not to manipulate coding for perceived financial gain or to satisfy unstated payer expectations. This can be construed as fraudulent activity. Professionals should employ a decision-making framework that prioritizes thorough review of clinical documentation, meticulous application of the ICD-10-CM official guidelines for coding and reporting, and consultation with coding resources or supervisors when ambiguity arises. The process should involve identifying all documented diagnoses, understanding the relationships between them, and selecting the code that most precisely describes each condition based on the provided documentation and established coding conventions. Question 8. Investigation of a medical record reveals a physician performed a complex surgical procedure and also documented a separate, distinct diagnostic imaging study during the same operative session. The physician's operative report clearly details the rationale for ordering and performing this imaging study as a critical step in assessing the patient's condition during the surgery, beyond what is typically included in the primary procedure. The coder is unsure if the imaging study should be billed separately or if it is considered bundled with the primary surgical code. Option A. Do not bill the imaging study separately, assuming it is bundled with the primary surgical procedure, as it was performed during the same operative session. Option B. Bill the imaging study using a reduced payment rate, as it was performed concurrently with a more extensive procedure. Option C. Bill the imaging study separately using the appropriate CPT code and modifier, as the documentation supports its distinct medical necessity and performance beyond the scope of the primary surgical procedure. Option D. Query the physician for clarification on whether the imaging study was essential, without independently reviewing coding guidelines or NCCI edits. Correct answer is C. Bill the imaging study separately using the appropriate CPT code and modifier, as the documentation supports its distinct medical necessity and performance beyond the scope of the primary surgical procedure. Explanation. Scenario analysis. This scenario presents a common challenge in medical coding, where a provider documents a service that appears to be bundled with another, more comprehensive service already reported. The coder must determine if the documented service is truly distinct and separately billable, or if it falls under the umbrella of the primary service. This requires a deep understanding of coding guidelines, payer policies, and the specific clinical context. Misinterpreting this can lead to undercoding, missing revenue, or overcoding, fraudulent billing, both of which have significant financial and legal repercussions. The professional challenge lies in balancing accurate representation of services rendered with adherence to strict billing regulations. Correct approach analysis. The correct approach involves a systematic review of the medical record, coding guidelines, and payer policies. This includes consulting the National Correct Coding Initiative, NCCI, edits, which are designed to prevent improper payment for procedures and services that are bundled or unbundled. If the NCCI edits indicate a bundle, The coder must then look for specific documentation that supports medical necessity and distinctness of the service. This might involve reviewing operative reports, physician notes, and diagnostic test results. If the documentation clearly supports that the service was performed separately and was medically necessary beyond the primary procedure, then it can be coded with the appropriate modifier. This approach upholds the principle of accurate coding, ensuring that all services rendered are appropriately captured and reimbursed according to established rules, thereby complying with regulations like the False Claims Act and Medicare's billing requirements. Incorrect approaches analysis. One incorrect approach is to automatically assume that any service documented alongside a more comprehensive procedure is bundled and therefore not billable. This fails to consider situations where a service is indeed distinct and medically necessary, leading to potential undercoding and lost revenue. Ethically, it fails to represent the full scope of services provided. Another incorrect approach is to code the service separately without thoroughly reviewing the NCCI edits or the supporting documentation. This could lead to billing for services that are considered bundled by the payer, resulting in improper payments and potential violations of fraud and abuse statutes. This demonstrates a lack of due diligence and adherence to established coding standards. A third incorrect approach is to rely solely on the provider's request to bill a service without independent verification. While provider input is valuable, the coder is ultimately responsible for ensuring compliance with coding and billing regulations. Blindly following a provider's instruction without applying coding knowledge and checking guidelines can lead to erroneous billing. Professional reasoning. Professionals should employ a decision-making framework that prioritizes accuracy and compliance. This involves 1. Thoroughly reviewing the medical record to understand the services performed in the clinical context. 2. Consulting official coding guidelines, e.g., CPT, IC 10cm, and payer-specific policies. 3. Applying NCCI edits to identify potential bundling issues. 4. If a bundle is identified, critically evaluating the documentation for evidence of medical necessity and distinctness of the service. 5. If justification exists, applying appropriate modifiers as per coding guidelines. 6. Documenting the rationale for coding decisions, especially in complex cases. This systematic process ensures that coding decisions are defensible, compliant, and ethically sound. Question 9. What factors determine the appropriate coding of social determinants of health, S2H, for a patient encounter, ensuring both clinical relevance and adherence to payer guidelines? Option A. The presence of documented social or economic factors in the patient's medical record that directly impact their health status, treatment plan, or prognosis, as supported by payer-specific coding guidelines. Option B. Desire to capture data for public health research initiatives, even if the S2H factors are not directly related to the patient's current medical condition or treatment. Option C. The coder's personal belief about how a patient's social circumstances might affect their health, even if not explicitly documented or clinically linked. Option D. Any mention of a patient's living situation or financial status in casual conversation during the visit, regardless of its clinical relevance or documentation. The correct answer is A. The presence of documented social or economic factors in the patient's medical record that directly impact their health status, treatment plan, or prognosis, as supported by payer-specific coding guidelines. Explanation. This scenario presents a professional challenge due to the ethical considerations involved in accurately documenting and coding for social determinants of health. S2H. Medical coders and billers must balance the need for comprehensive patient care documentation with patient privacy and the potential for bias or misinterpretation of S2H data. The challenge lies in ensuring that S2H codes are used appropriately to reflect clinical relevance and improve patient outcomes, without leading to discriminatory practices or misrepresenting the patient's condition. Careful judgment is required to discern when S2H factors are directly impacting the patient's health status and require specific coding. The correct approach represents best professional practice because it prioritizes accurate, clinically relevant coding that supports patient care and public health initiatives. By focusing on documented S2H factors that directly influence a patient's health status and treatment plan, coders ensure that the codes reflect a true clinical picture. This aligns with the intent of S2H coding, which is to improve understanding of health disparities and inform interventions. Adhering to payer guidelines and established coding conventions for S2H ensures compliance and proper reimbursement, while also contributing to data that can drive improvements in healthcare delivery and address systemic inequities. An incorrect approach that solely relies on assumptions or patient self-reporting without clinical correlation fails to meet professional standards. This can lead to inaccurate coding, potentially misrepresenting the patient's condition and impacting treatment decisions or research data. It also risks violating patient privacy if sensitive information is coded without a clear clinical link. Another incorrect approach that ignores S-Do-H factors altogether, even when they are clearly impacting the patient's health, is a failure to provide a complete and accurate representation of the patient's needs. This can result in inadequate care planning and missed opportunities for targeted interventions. Furthermore, failing to follow specific payer guidelines for S-Do-H coding can lead to claim denials and financial repercussions, as well as potential compliance issues. Professionals should employ a decision-making framework that begins with a thorough review of the patient's medical record. This includes identifying any documented S-Do-H factors that have a direct impact on the patient's current medical condition, treatment, or prognosis. Coders must then consult payer-specific guidelines and official coding advice to determine the appropriate ICD-10-CM codes for these documented S-Do-H factors. If a documented S-Do-H factor is not clearly linked to a current medical condition or treatment, it should not be coded unless specific payer guidance dictates otherwise. This systematic approach ensures accuracy, compliance, and ethical practice. Question 10. When evaluating a physician's progress note for a patient encounter, the medical coder encounters the term gastric distress, documented as the primary reason for the visit. The coder is unsure if this refers to a specific diagnosis like gastritis, dyspepsia, or a more general symptom of discomfort. What is the most appropriate course of action for the medical coder to ensure accurate coding and billing? Option A. Contact the ordering physician to request clarification on the specific diagnosis represented by gastric distress. Option B. Code gastric distress as a symptom code and wait for further documentation from the physician. Option C. Assume gastric distress refers to the most common condition associated with such symptoms and assign the corresponding code. Option D. Interpret gastric distress based on personal understanding of common medical terminology and select the most fitting code. The correct answer is A. Contact the ordering physician to request clarification on the specific diagnosis represented by gastric distress. Explanation. Scenario analysis. This scenario presents a professional challenge due to the potential for misinterpretation of medical terminology, which can lead to significant errors in patient care and billing. The coder must navigate the nuances of medical language to accurately reflect the physician's documentation, ensuring both patient safety and compliance with billing regulations. The ethical dilemma arises from the responsibility to maintain accuracy and integrity in medical records and billing, even when faced with potentially ambiguous or incomplete information. Correct approach analysis. The correct approach involves seeking clarification from the ordering physician. This is best professional practice because it directly addresses the ambiguity in the documentation. Accurate medical coding relies on precise understanding of the terms used. By consulting the physician, the coder ensures that the diagnosis and procedure codes assigned are a true reflection of the patient's condition and the services rendered. This aligns with the ethical obligation to provide accurate information and the regulatory requirement for precise coding to support billing claims. It prevents the submission of inaccurate claims, which could lead to audits, penalties, and a loss of trust. Incorrect approach is analysis. One incorrect approach is to assume the meaning of the term based on common usage or personal interpretation. This is a regulatory and ethical failure because it introduces a high risk of miscoding. Medical terminology can have specific, technical meanings that differ from everyday language. Making assumptions bypasses the fundamental principle of coding based on documented facts, potentially leading to incorrect diagnoses being recorded, inappropriate treatments being billed, and ultimately, fraudulent claims. This violates the principle of accuracy and integrity in medical records and billing. Another incorrect approach is to code based on the most common condition associated with the documented symptoms without seeking further information. This is a regulatory and ethical failure because it is speculative and not based on definitive documentation. While a common condition might be a possibility, it is not a certainty. Coding based on probability rather than documented fact is a violation of coding guidelines and ethical standards. It can lead to overcoding or undercoding, impacting reimbursement, and potentially misrepresenting the patient's health status. A third incorrect approach is to leave the diagnosis blank or use a generic code until further information is available, without attempting to clarify. While caution is important, this approach can delay billing and negatively impact practice revenue. More importantly, it fails to fulfill the coder's responsibility to accurately represent the documented encounter. The goal is to achieve accurate coding through clarification, not to avoid the task by leaving it incomplete or overly generalized, which can still lead to downstream issues if not properly resolved. Professional reasoning. When faced with ambiguous medical terminology, a medical coder should follow a structured decision-making process. 1. Identify the ambiguity. Recognize that the term is unclear or could have multiple interpretations. 2. Consult documentation. Review the entire patient record for any contextual clues or further explanation. 3. Seek clarification. If ambiguity persists, the primary recourse is to contact the ordering physician or the physician responsible for the documentation. This is the most direct and reliable method to ensure accurate understanding. 4. Document the clarification. Record the physician's response and the rationale for the chosen code. 5. Code accurately. Assign codes based on the clarified information and established coding guidelines. This process prioritizes accuracy, ethical responsibility, and regulatory compliance, ensuring that medical records and billing are both precise and defensible. Question 11. The control framework reveals a medical record for a patient admitted with acute exacerbation of congestive heart failure. The patient also has a documented history of chronic essential hypertension. The physician's documentation clearly indicates that the heart failure exacerbation was the primary reason for the admission and required immediate intervention. Based on the ICD-10-CM official coding guidelines, which of the following coding approaches best reflects the principal diagnosis and secondary diagnosis for this encounter? Option A. Assign the chronic essential hypertension as the principal diagnosis and the acute exacerbation of congestive heart failure as a secondary diagnosis. Option B. Assign the acute exacerbation of congestive heart failure as the principal diagnosis, omitting the chronic hypertension. Option C. Assign both the acute exacerbation of congestive heart failure and the chronic essential hypertension as principal diagnoses. Option D. Assign the acute exacerbation of congestive heart failure as the principal diagnosis and the chronic essential hypertension as a secondary diagnosis. The correct answer is D. Assign the acute exacerbation of congestive heart failure as the principal diagnosis and the chronic essential hypertension as a secondary diagnosis. Explanation. Scenario analysis. This scenario presents a common challenge in medical coding, accurately assigning ICD-10-CM codes when a patient has multiple coexisting conditions that influence the primary diagnosis and its management. The difficulty lies in understanding the hierarchical relationship between diagnoses and applying the official ICD-10-CM coding guidelines to ensure the principal diagnosis is correctly identified, reflecting the condition chiefly responsible for the admission or encounter. Misinterpreting these guidelines can lead to inaccurate billing, improper reimbursement, and potentially flawed quality reporting. Correct approach analysis. The correct approach involves a thorough review of the medical record to identify all documented diagnoses. Subsequently, the coder must apply the ICD-10-CM official guidelines for coding and reporting, specifically focusing on Chapter 14, endocrine, nutritional and metabolic diseases, and mental, behavioral, and neurodevelopmental disorders, and Chapter 9, diseases of the circulatory system, guidelines related to sequencing. The guideline for sequencing states that the principal diagnosis is defined as the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for inpatient hospital services. In this case, while hypertension is a chronic condition, the acute exacerbation of heart failure, directly leading to the admission and requiring specific treatment, is the condition chiefly responsible. Therefore, coding the acute heart failure as the principal diagnosis, followed by the chronic hypertension as a secondary diagnosis, accurately reflects the patient's condition and the reason for care, aligning with best professional practice and regulatory requirements for accurate coding. Incorrect approaches analysis. Coding the chronic hypertension as the principal diagnosis would be incorrect because it was not the condition chiefly responsible for the admission. Patient was admitted due to the acute exacerbation of heart failure. This failure to identify the principal diagnosis according to the guidelines leads to regulatory noncompliance, as it misrepresents the primary reason for the encounter. Coding only the acute heart failure without including the chronic hypertension as a secondary diagnosis is also incorrect. While the heart failure is the principal diagnosis, chronic hypertension is a coexisting condition that impacts patient care and should be documented. Failing to code all relevant diagnoses can lead to incomplete medical records and potentially affect quality metrics in future care planning, representing an ethical and regulatory lapse. Coding the acute heart failure and chronic hypertension as principal diagnoses simultaneously is not possible according to ICD-10-CM sequencing rules, which require a single principal diagnosis. This approach demonstrates a misunderstanding of the fundamental principles of diagnostic coding and sequencing guidelines. Professional reasoning. Professionals should employ a systematic decision-making framework. 1. Thoroughly review the entire medical record, including physician's notes, discharge summaries, and diagnostic reports. 2. Identify all documented diagnoses and their acuity, acute vs. chronic. 3. Consult the official ICD-10-CM coding guidelines, paying close attention to chapters relevant to the documented conditions and general sequencing rules. 4. Determine the condition chiefly responsible for the admission or encounter, applying the definition of the principal diagnosis. 5. Sequence secondary diagnoses to reflect coexisting conditions that affect patient care. 6. Verify the accuracy of the assigned codes against the medical documentation and coding guidelines. 7. If ambiguity exists, query the physician for clarification to ensure accurate and compliant coding. Question 12. The evaluation methodology shows that a physician performed a bilateral surgical procedure, with one side requiring a more extensive approach than the other. The coder needs to select the appropriate CPT modifier to accurately report this scenario for billing purposes. Which of the following modifier applications best reflects the professional practice for this situation? Option A. Append modifier 50 to the CPT code for the bilateral procedure, and append modifier 52 to the CPT code for the less extensive procedure. Option B. Append modifier 50 to the CPT code for the bilateral procedure, and append modifier 52 to the CPT code for the more extensive procedure. Option C. Append modifier 50 to the CPT code for the bilateral procedure, and append modifier 22 to the CPT code for the more extensive procedure. Option D. Append modifier 22 to the CPT code for the more extensive procedure, indicating increased procedural services. The correct answer is D. Append modifier 22 to the CPT code for the more extensive procedure, indicating increased procedural services. Explanation. The evaluation methodology shows that a medical coder is tasked with accurately reporting services rendered by a physician. This scenario is professionally challenging because the correct application of CPT modifiers is crucial for proper reimbursement and compliance with payer policies. Misapplication can lead to claim denials, audits, and potential fraud allegations. Careful judgment is required to select the modifier that precisely reflects the circumstances of the service without altering its basic definition. The correct approach represents best professional practice because it demonstrates a thorough understanding of CPT coding guidelines and payer requirements. By selecting the modifier that accurately describes the additional service or circumstance without changing the fundamental meaning of the CPT code, the coder ensures that the claim accurately reflects the work performed. This aligns with the principles of accurate reporting and ethical billing practices mandated by regulatory bodies like the Centers for Medicare and Medicaid Services, CMS, and private payers. An incorrect approach that involves appending a modifier to indicate a service that was not actually performed represents a direct violation of coding guidelines and potentially fraudulent billing. This is an ethical failure and a regulatory violation, because it misrepresents the services provided to obtain improper payment. Another incorrect approach, such as omitting a required modifier when specific circumstances warrant its use, can lead to underpayment or incorrect data collection. hindering accurate healthcare statistics and potentially violating payer policies that mandate specific reporting for certain situations. Failing to consult payer-specific guidelines when appending modifiers is also an ethical and regulatory failure, as many payers have specific rules and limitations on modifier usage that supersede general CPT guidelines. The professional reasoning process for similar situations involves a systematic approach. First, thoroughly understand the CPT code and the service provided. Second, review the CPT manual's general guidelines and specific code descriptions for any applicable modifiers. Third, consult payer-specific policies, e.g., Medicare's National Correct Coding Initiative, NCCI edits, Medicare Administrative Contractor, MAC, guidance, or commercial payer policies, as they often provide additional instructions or limitations on modifier use. Finally, document the rationale for modifier selection clearly in the patient's medical record. Question 13. Operational review demonstrates that a general surgeon performed a laparoscopic cholecystectomy and a laparoscopic appendectomy during the same operative session on a Medicare patient. The operative report clearly details both procedures as distinct and separate from each other. Based on the Medicare Physician Fee Schedule and NCCI edits, which of the following approaches best ensures accurate coding and billing for this encounter? Option A. Report only the laparoscopic cholecystectomy, as it is the primary procedure, and do not report the appendectomy. Option B. Report the laparoscopic cholecystectomy with modifier 51 and the laparoscopic appendectomy as a separately billable procedure. Option C. Report the laparoscopic cholecystectomy as the primary procedure and the laparoscopic appendectomy as a separately billable procedure without a modifier. Option D. Report the laparoscopic cholecystectomy with modifier 51 and the laparoscopic appendectomy with modifier 59. The correct answer is B. Report the laparoscopic cholecystectomy with modifier 51 and the laparoscopic appendectomy as a separately billable procedure. Explanation. Scenario analysis. This scenario presents a common challenge in surgical coding where multiple procedures are performed during a single operative session. The professional challenge lies in accurately identifying and reporting all services rendered to ensure appropriate reimbursement while adhering to coding guidelines and payer policies. Misinterpretation of bundled services or modifier usage can lead to underpayment or overpayment, both of which have significant financial and compliance implications. Correct approach analysis. The correct approach involves a thorough review of the operative report, physician's documentation, and relevant coding guidelines, specifically focusing on the National Correct Coding Initiative, NCCI, edits and payer-specific policies, identifying the primary procedure, and then determining if subsequent procedures are separately billable or bundled is crucial. The use of appropriate modifiers, such as modifier 51, multiple procedures, or modifier 59, distinct procedural service, when applicable and supported by documentation, is essential for accurate reporting. This approach ensures compliance with coding standards, promotes accurate billing, and reflects the complexity of the services provided, aligning with the principles of ethical and professional medical coding. Incorrect approaches analysis. Reporting only the highest paying procedure without considering other separately billable services is a failure to accurately represent the work performed, potentially leading to underpayment and violating the principle of reporting all services rendered. This also fails to comply with NCCI edits that may allow for separate reporting of certain procedures under specific circumstances. Applying modifier 51 to all secondary procedures without verifying if they are truly distinct and separately reportable according to NCCI edits or payer guidelines is incorrect. Modifier 51 is used to indicate multiple procedures performed at the same session, but its application is subject to specific rules and may not be appropriate for all secondary procedures, especially those that are integral to the primary procedure or are considered inherently bundled. This can lead to incorrect reimbursement and potential audit findings. Using modifier 59 indiscriminately for any secondary procedure performed without sufficient documentation to support its distinct and independent nature is a significant ethical and regulatory failure. Modifier 59 is intended for specific circumstances where a procedure is performed at a different session, different site, or different procedure or surgery not normally associated with the primary procedure. Misusing this modifier can result in fraudulent billing and severe penalties. Professional reasoning. Professionals should approach this situation by first understanding the operative report in its entirety. They must then consult the most current ICD-10-CM and CPT coding manuals, paying close attention to any NCCI edits or payer-specific guidelines that pertain to the procedures performed. When multiple procedures are involved, the coder must determine the primary procedure and then systematically evaluate each secondary procedure for its billability, considering bundling rules and the necessity of modifiers. Documentation is paramount. If the operative report does not clearly support separate reporting or the use of a specific modifier, the coder should query the physician for clarification rather than making assumptions. This systematic, evidence-based approach ensures accuracy, compliance, and ethical practice. Question 14. Benchmark analysis indicates that a patient presents with a series of laboratory results showing elevated liver enzymes, a positive serological marker for a specific hepatitis virus, and a biopsy report confirming inflammation and fibrosis. The physician's progress note states, patient exhibits signs and symptoms consistent with chronic hepatitis B, further management plan. Which of the following approaches best reflects accurate ICD-10-CM coding for this pathology and laboratory service? Option A. Assign an ICD-10-CM code for elevated liver enzymes as the primary diagnosis, as this is a direct laboratory finding. Option B. Assign an ICD-10-CM code for chronic hepatitis B, supported by the serological marker, biopsy findings, and physician's assessment. Option C. Assign an ICD-10-CM code for abnormal serological marker without a confirmed diagnosis, as the biopsy is still pending final interpretation. Option D. Assign a general ICD-10-CM code for liver disease, as the specific type of hepatitis is not definitively stated in the physician's note. The correct answer is B. Assign an ICD-10-CM code for chronic hepatitis B, supported by the serological marker, biopsy findings, and physician's assessment. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the medical coder to interpret complex laboratory test results and accurately assign ICD-10-CM codes that reflect the physician's diagnostic reasoning, not just the technical findings. The challenge lies in understanding the clinical context and the relationship between multiple laboratory values to determine the most specific and appropriate diagnosis code, ensuring accurate reimbursement and patient record integrity. Misinterpretation can lead to undercoding or overcoding, both of which have significant financial and compliance implications. Correct approach analysis. The correct approach involves a thorough review of the entire patient encounter, including the physician's documented assessment and plan, alongside the pathology and laboratory reports. This allows the coder to identify the definitive diagnosis supported by the clinical evidence. For pathology and laboratory services, the ICD-10-CM coding guidelines emphasize coding to the highest level of specificity supported by the documentation. If the physician has documented a definitive diagnosis based on the lab results, that diagnosis should be coded. If the results are abnormal but no definitive diagnosis is yet established, codes for abnormal findings or the signs/symptoms leading to the testing may be appropriate, as per ICD-10-CM official guidelines for coding and reporting. This approach ensures compliance with coding standards and accurately reflects the patient's condition. Incorrect approach is analysis. One incorrect approach is to solely code based on the most abnormal single laboratory value without considering the physician's overall assessment or other related findings. This fails to capture the complete clinical picture and may lead to coding a symptom or finding that is not the primary reason for the encounter or the definitive diagnosis. This violates the principle of coding to the highest specificity and can result in inaccurate data. Another incorrect approach is to code based on a preliminary or suspected diagnosis that is not yet confirmed by the physician in the documentation. ICD-10-CM guidelines generally prohibit coding for conditions that are only suspected, uncertain, or ruled out. Relying on such information can lead to improper billing and misrepresentation of the patient's health status. A third incorrect approach is to assign a very general code for a broad category of findings when more specific codes are available and supported by the documentation. This is a form of undercoding that does not accurately reflect the patient's condition and can impact quality reporting and research data. It fails to meet the requirement of coding to the highest level of specificity. Professional reasoning. Medical coders must adopt a systematic approach that prioritizes thorough documentation review. This includes understanding the physician's diagnostic process, the interplay of laboratory results, and the specific ICD-10-CM coding guidelines. When faced with complex lab data, coders should query the physician for clarification if the documentation is ambiguous or incomplete, rather than making assumptions. This ensures that the assigned codes are accurate, compliant, and ethically sound, reflecting the true clinical picture of the patient's encounter. Question 15. Market research demonstrates a growing need for granular data on injury causation to inform public health initiatives. A medical coder is reviewing a patient encounter for a fall sustained while walking on a public sidewalk. The physician's documentation clearly states the patient tripped and fell, resulting in a fractured wrist. The payer's policy for this specific service does not mandate the use of external cause codes for reimbursement. What is the most appropriate coding approach in this scenario? Option A. Assign the appropriate ICD-10-CM diagnosis code for the fractured wrist and omit external cause codes, as they are not required for reimbursement by this payer. Option B. Assign the appropriate ICD-10-CM diagnosis code for the fractured wrist and query the physician for additional details about the fall, even if the current documentation is sufficient to assign a specific external cause code. Option C. Assign the appropriate ICD-10-CM diagnosis code for the fractured wrist and select the most specific external cause code, S, that describe the circumstances of the fall, e.g., place of occurrence, activity. Option D. Assign the appropriate ICD-10-CM diagnosis code for the fractured wrist and assign a generic external cause code for fall without further specificity, as the payer does not require detailed information. The correct answer is A. Assign the appropriate ICD-10-CM diagnosis code for the fractured wrist and omit external cause codes, as they are not required for reimbursement by this payer. Explanation. This scenario presents a common implementation challenge in medical coding and billing, accurately capturing the external causes of injury. The challenge lies in the fact that external cause codes are not always mandatory for reimbursement, but are crucial for public health data collection, research, and understanding injury trends. A biller must navigate the payer's specific requirements, the physician's documentation, and the coding guidelines to ensure both compliance and completeness. The correct approach involves thoroughly reviewing the physician's documentation for any mention of how, where, and when the injury occurred, and then selecting the most specific external cause code, S, that accurately reflect this information, even if not explicitly required by the payer for payment. This aligns with the principles of accurate and complete coding as mandated by coding guidelines and ethical professional practice. It supports comprehensive data collection, which is vital for injury prevention initiatives and public health research. An incorrect approach would be to ignore external cause coding simply because the payer does not explicitly require it for reimbursement. This failure to code accurately and completely, even when not directly impacting immediate payment, violates the spirit of coding guidelines which aim for comprehensive data capture, can lead to incomplete statistical data, hindering public health efforts. Another incorrect approach is to assign a generic external cause code when more specific information is available in the documentation. This lack of specificity reduces the value of the data collected and does not fully represent the circumstances of the injury. Finally, assuming the external cause is irrelevant to the patient's care and therefore not documenting it is a failure to recognize the importance of external cause codes in understanding the full context of an injury. Professionals should approach such situations by first understanding the payer's specific coding requirement for external causes. However, they must also be aware of the broader importance of these codes for public health. When documentation provides sufficient detail, the professional decision-making process should prioritize selecting the most specific and accurate external cause codes available, regardless of immediate reimbursement implications, to ensure data integrity and support public health objectives. Question 16. Process analysis reveals that a radiologist requests a specific CPT code for a diagnostic imaging study, stating it best represents the complexity of the interpretation. However, the detailed dictated report and associated imaging findings in the medical record do not fully support the level of complexity indicated by the requested code, suggesting a lower-level code might be more appropriate based on standard coding guidelines. As a medical coding and billing specialist adhering to MCBS regulations, what is the most appropriate course of action? Option A. Query the radiologist for clarification regarding the documentation and the rationale for the requested code, explaining the discrepancy with the dictated report and coding guidelines, and then assign the code that most accurately reflects the documented findings after receiving a response. Option B. Sign the CPT code requested by the radiologist, assuming their clinical judgment supersedes the coder's interpretation of the documentation. Option C. Refuse to assign any code for the service until the radiologist provides a revised report that explicitly justifies the higher-level code. Option D. Assign a higher-level CPT code than what is documented to ensure the radiologist's effort is adequately compensated, as per their request. The correct answer is A. Query the radiologist for clarification regarding the documentation and the rationale for the requested code, explaining the discrepancy with the dictated report and coding guidelines, and then assign the code that most accurately reflects the documented findings after receiving a response. Explanation. This scenario presents a professional challenge due to the inherent conflict between a physician's request for a specific code and the coder's responsibility to accurately reflect the services rendered based on documentation and coding guidelines. The challenge lies in upholding coding integrity and compliance while navigating a potential pressure to misrepresent services. The correct approach represents best professional practice because it prioritizes accurate and compliant coding, adhering strictly to the principles of medical coding, and billing as outlined by the MCBS regulatory framework. This involves a thorough review of the medical record to ensure the chosen code accurately reflects the diagnostic and procedural information. When a discrepancy exists between the physician's request and the documentation, the coder has an ethical and regulatory obligation to query the physician for clarification, or to assign the code that is most appropriate based on the documented findings, rather than blindly accepting a potentially inaccurate code. This upholds the integrity of medical records and billing, preventing fraud and abuse. An incorrect approach of assigning the requested code without verification fails to adhere to the MCBS guidelines for accurate coding. This can lead to improper billing, potentially overcoding or undercoding services, which violates principles of ethical billing and can result in financial penalties and reputational damage. Assigning a code based solely on a physician's request, especially when it appears to contradict the documented findings, can be construed as complicity in fraudulent billing practices. Another incorrect approach of refusing to code the service without further discussion with the physician, while stemming from a desire for accuracy, is not the most effective professional response. While querying the physician is crucial, a complete refusal to engage in the coding process without attempting to understand the physician's rationale or seeking clarification can hinder patient care and create unnecessary delays. The professional approach involves a collaborative effort to ensure accuracy. A further incorrect approach of assigning a more complex code than documented to cover the physician's perceived effort, even if well-intentioned, is a direct violation of coding ethics and regulations. This constitutes upcoding, a form of fraud, and undermines the entire purpose of accurate medical coding, which is to reflect the services actually performed and the conditions treated. The professional decision-making process for similar situations should involve 1. Thoroughly reviewing the medical documentation to understand the patient's condition and the services provided. 2. Comparing the physician's request with the documented information and relevant coding guidelines. 3. If a discrepancy exists, initiating a professional query to the physician to seek clarification on the documentation or the intended service. 4. Assigning the code that most accurately and compliantly reflects the documented services and diagnoses. 5. Documenting all queries and the rationale for the final code selection. Question 17. Stakeholder feedback indicates that coders are sometimes inconsistent in applying external cause codes for injuries and poisonings. A patient presents with a fractured tibia sustained during a fall while walking on an icy sidewalk. The provider documents the fracture and notes the fall was accidental. Which approach best ensures accurate coding and compliance with ICD-10-CM guidelines? Option A. Sign the ICD-10-CM code for the fractured tibia and query the provider to determine if the fall was intentional. Option B. Assign the ICD-10-CM code for the fractured tibia and add a code for patient's perception of ice. Option C. Assign the ICD-10-CM code for the fractured tibia as the principal diagnosis and append the appropriate external cause code for accidental fall on ice. Option D. Assign only the ICD-10-CM code for the fractured tibia, as the external cause is considered secondary information. The correct answer is C. Assign the ICD-10-CM code for the fractured tibia as the principal diagnosis and append the appropriate external cause code for accidental fall on ice. Explanation: this scenario is professionally challenging because accurately coding injuries and poisonings requires a thorough understanding of the ICD-10-CM coding guidelines, specifically those pertaining to external causes of morbidity and mortality. The complexity arises from the need to capture not only the nature of the injury or poisoning, but also the circumstances surrounding it, which are crucial for public health data collection and reimbursement. Misinterpretation or omission of key details can lead to inaccurate billing, delayed payments, and potential compliance issues. The correct approach represents best professional practice because it prioritizes adherence to the ICD-10-CM official guidelines for coding and reporting. Specifically, it emphasizes the importance of identifying the principal diagnosis and then assigning the appropriate external cause codes, V, W, X, Y codes, and intent codes, e.g., accidental, intentional self-harm, assault, when available and documented. This ensures that the full clinical picture is represented, facilitating accurate data analysis for injury prevention and public health initiatives, as well as supporting appropriate reimbursement based on the documented services and conditions. An incorrect approach that fails to assign external cause codes when documented and relevant is a regulatory failure. The ICD-10-CM guidelines mandate the reporting of external causes of injury and poisoning whenever the information is available and the condition is being treated. Omitting these codes means that crucial data for understanding injury patterns and trends is lost, which is a violation of reporting requirements. Another incorrect approach that involves assigning external cause codes without sufficient documentation from the provider is an ethical and regulatory failure. Coders must rely on the provider's documentation to assign codes. Speculating or inferring external causes without explicit documentation can lead to inaccurate coding and potentially fraudulent billing practices. This violates the principle of coding based on documented facts. A further incorrect approach that focuses solely on the injury code without considering the poisoning aspect when both are present and documented is also a failure. ICD-10-CM has specific guidelines for coding poisonings and their effects, which may differ from coding traumatic injuries. Failing to differentiate and code appropriately for poisoning can lead to incorrect classification of the patient's condition and subsequent treatment. The professional decision-making process for similar situations involves a systematic review of the medical record. This includes identifying the primary reason for the encounter, all documented diagnoses, and any information related to the circumstances of the injury or poisoning. Coders should then consult the ICD-10-CM coding manual and official guidelines to select the most accurate and specific codes. If documentation is unclear or insufficient, the coder must query the provider for clarification before assigning codes. This iterative process ensures compliance and accuracy. Question 18. The risk matrix shows a moderate likelihood of claim denials for prosthetic and orthotic services due to coding inaccuracies. A patient has received a custom fabricated knee brace prescribed by their physician for post-operative support. The brace is described by the supplier as a dynamic adjustable hinged knee brace. Which of the following best represents the most appropriate coding and billing approach to mitigate this risk? Option A. Assume the brace is covered based on previous similar claims and use the most commonly billed code for knee braces without consulting current payer policies. Option B. Assign the most specific HCPCS level Roman II code that accurately describes the dynamic adjustable hinged knee brace, ensuring the physician's order and supplier documentation clearly support the medical necessity and the specific features of the device. Option C. Use a general HCPCS level Roman II code for knee brace, as the specific details of the brace are not critical for reimbursement. Option D. Bill using the code provided by the supplier on their invoice without independently verifying its accuracy against the physician's order and clinical documentation. The correct answer is B. Assign the most specific HCPCS level Roman II code that accurately describes the dynamic adjustable hinged knee brace, ensuring the physician's order and supplier documentation clearly support the medical necessity and the specific features of the device. Explanation. The scenario presents a common challenge in medical coding and billing, accurately assigning codes for prosthetics and orthotics, which often involves understanding the specific device, its purpose, and the payer's policies. The complexity arises from the wide variety of devices, the need for precise documentation from the prescribing physician and the supplier, and the varying coverage guidelines of different insurance plans. Miscoding can lead to claim denials, financial loss for the provider, and potential compliance issues. Correct approach involves a thorough review of the patient's medical record, including the physician's order, the supplier's detailed description of the prosthetic or orthotic device, and any relevant clinical notes. This information is then cross-referenced with the appropriate coding manuals, e.g., HCPCS Level Roman II and payer-specific policies. The goal is to select the most specific and accurate code that reflects the service provided and the device dispensed, ensuring compliance with all applicable regulations and guidelines. This meticulous process minimizes the risk of errors and supports accurate reimbursement. An incorrect approach would be to assign a generic code without verifying the specific details of the device or its medical necessity. This fails to meet the requirement for specificity in coding, potentially leading to claims being rejected for insufficient information or for using a code that does not accurately represent the service. Another incorrect approach is to rely solely on the supplier's invoice without independent verification against the physician's order and clinical documentation. This bypasses the essential step of confirming medical necessity and the appropriateness of the device for the patient's condition, which is a fundamental ethical and regulatory requirement. Furthermore, assuming coverage based on past similar claims without consulting current payer policies is a significant risk, as coverage criteria can change, leading to non-compliance and financial repercussions. Professional decision-making in such situations requires a systematic approach. First, obtain and review all supporting documentation. Second, consult the relevant coding resources for the most accurate code. Third, research and understand the specific payer's policies for prosthetics and orthotics. And finally, ensure all documentation supports the chosen code and the medical necessity of the device. This structured process, grounded in regulatory compliance and ethical practice, is crucial for accurate and efficient medical billing. Question 19. The monitoring system demonstrates that a nurse practitioner provided a wound debridement service, during which sterile gauze and a specific topical antibiotic ointment were used. The billing specialist is preparing the claim. Which of the following coding and billing approaches best reflects compliance with Medicare regulations for this scenario? Option A. Bill for the wound debridement service and report the gauze using a generic supply code, omitting the antibiotic ointment as it is a prescription item not covered by Medicare for this type of service. Option B. Bill for the wound debridement service and report the gauze and antibiotic ointment using HCPCS Level Roman II codes, but attribute the supplies to the physician who oversees the nurse practitioner's practice rather than the nurse practitioner who rendered the service. Option C. Bill for the wound debridement service using the appropriate CPT code and separately report the gauze and antibiotic ointment using their respective HCPCS Level Roman II codes, ensuring both are linked to the nurse practitioner's billing information and the appropriate diagnosis. Option D. Bill only for the wound debridement service, as supplies are considered incidental to the physician service and not separately billable by non-physician practitioners. The correct answer is C. Bill for the wound debridement service using the appropriate CPT code and separately report the gauze and antibiotic ointment using their respective HCPCS Level Roman II codes, ensuring both are linked to the nurse practitioner's billing information and the appropriate diagnosis. Explanation. This scenario is professionally challenging because accurately coding for supplies and non-physician services requires a thorough understanding of payer-specific guidelines, the nature of the service provided, and the correct identification of the rendering provider. The MCBS exam emphasizes the importance of precise coding to ensure appropriate reimbursement and compliance with federal regulations, particularly the Medicare guidelines. The correct approach represents best professional practice because it aligns with the principles of accurate medical coding and billing as mandated by Medicare. Properly identifying and coding for supplies used during a non-physician service ensures that the provider is reimbursed for the materials consumed, and that the service itself is billed under the correct practitioner type and associated codes. This prevents underbilling or overbilling and maintains the integrity of patient records and billing claims. Adhering to Medicare's local coverage determinations, LCD, and national coverage determinations, NCD, for specific supplies and services is paramount. An incorrect approach that involves billing for supplies without a corresponding billable service is a direct violation of Medicare fraud and abuse statutes. Medicare reimburses for services rendered and supplies used in the provision of those services. Billing for supplies in isolation, without a documented and billable encounter, constitutes an improper claim. Another incorrect approach, such as using a generic supply code when a more specific payer-approved code exists, can lead to claim denials, audits, and potential penalties for inaccurate reporting. Furthermore, misrepresenting the type of non-physician service provided or the credentials of the rendering practitioner is a serious compliance issue, potentially leading to recoupment of payments and sanctions. Professionals should approach such situations by first identifying the specific non-physician service rendered and the supplies used. They must then consult the relevant Medicare guidelines, including LCDs and NCDs, to determine the appropriate procedure codes, diagnosis codes, and supply codes. Verification of the rendering practitioner's eligibility to bill Medicare for the service is also critical. If payer-specific guidelines differ from general Medicare rules, those specific guidelines must be followed. Documentation review is essential to ensure that the services and supplies billed are supported by the medical record. Question 20. Governance review demonstrates a need to reinforce understanding of ICD code structure among new medical coders. A patient record indicates a diagnosis of acute exacerbation of chronic obstructive pulmonary disease with lower respiratory infection. Which of the following best reflects the fundamental principle of selecting the appropriate ICD code for this scenario, considering the hierarchical and specific nature of ICD-10-CM? Option A. Prioritize the code for the acute exacerbation of COPD, as it is the primary condition, and append a less specific code for the infection if space allows. Option B. Utilize a code that broadly covers respiratory conditions, as the specific details of the infection are less critical for initial coding. Option C. Choose a general code for COPD exacerbation and a separate code for a respiratory infection, as long as both conditions are present. Option D. Select the most specific code that accurately captures both the exacerbation of COPD and the presence of the lower respiratory infection, as dictated by the ICD-10-CM coding guidelines. The correct answer is D. Select the most specific code that accurately captures both the exacerbation of COPD and the presence of the lower respiratory infection, as dictated by the ICD-10-CM coding guidelines. Explanation. Scenario analysis. This scenario is professionally challenging because accurate ICD coding is fundamental to proper patient care documentation, reimbursement, and public health statistics. Misinterpreting or misapplying ICD code structure can lead to incorrect billing, denied claims, and flawed data. The medical coder must possess a thorough understanding of the hierarchical nature of ICD codes and the specific conventions that govern their use to ensure compliance and accuracy. Correct approach analysis. The correct approach involves recognizing that ICD codes are structured hierarchically, moving from broader categories to more specific diagnoses. This structure is dictated by the official ICD coding guidelines, which are essential for consistent and accurate application. Understanding this hierarchy allows the coder to select the most specific code that accurately reflects the patient's condition, thereby ensuring proper documentation and reimbursement. This aligns with the core principles of medical coding accuracy and compliance with regulatory requirements for reporting diagnoses. Incorrect approaches analysis. One incorrect approach would be to select a code based solely on the first few characters without considering the subsequent characters that provide specificity. This fails to adhere to the ICD coding guidelines, which mandate the use of the most specific code available. This can lead to undercoding or incorrect coding, impacting reimbursement and data integrity. Another incorrect approach would be to assume that all codes within a particular chapter are interchangeable. ICD codes are designed with specific meanings and applications. Using a code that is not precisely aligned with the documented diagnosis violates the principle of accurate representation of patient conditions and can lead to compliance issues. A third incorrect approach would be to ignore the presence of combination codes or codes that require additional information for proper assignment. The ICD structure includes specific rules for certain conditions that are often coded together. Failing to recognize and apply these rules results in incomplete or inaccurate coding, which is a direct violation of coding standards and can have significant financial and legal repercussions. Professional reasoning. Professionals should approach ICD code selection by first identifying the primary reason for the patient encounter. Then, they should consult the ICD-10-CM tabular list and index, paying close attention to all instructional notes, conventions, and the hierarchical structure of the codes. The goal is always to find the most specific code that accurately describes the diagnosis as documented by the physician. If ambiguity exists, consulting the official ICD-10-CM coding guidelines or seeking clarification from the physician is paramount.